All right, thank you so much for rejoining us after our lunch break. We're going to begin immediately with session 2, and I will kick it to the facilitator, Lindsay.
Thanks, Lee. So welcome back. I'm Dr. Lindsay Botsford. I'm one of the PTAC members, and I get the privilege of facilitating this next session. So I'm happy to welcome our next session 4 experts who will share various perspectives on the availability and effectiveness of digital tools for equipping patients with information about their healthcare. You can find their full biographies and slides posted on the ASPE PTAC website and the public meeting registration site. At this time, I ask our session participants to turn on your video. Looks like you're all good. After our experts have presented, our committee members will have plenty of time to ask questions. To kick it off, first, we're excited to welcome Mr. Vishal Gondal, who's the founder and chief executive officer of Goki. Welcome, Vishal.
Thank you. Thanks a lot for inviting me at this prestigious event. I will get started with my slides. I think I'm just waiting for Amy to put that together. So quick background, I actually started my career in the world of video games, and I ended up creating, when I was in school, I started the company and I ended up creating one of India's biggest video games company. Ended up selling it to Walt Disney in 2012. And since then, from 2014, I started working on my next startup, which is Goki. Goki combines healthcare with the world of gaming. And I know it sounds interesting for a lot of people because if you really see the problem which we are trying to solve, you will realize that how a lot of healthcare challenges stem from how gaming can really solve it. A little bit about Goki. We are now 10 years in the business. We have presence in multiple geographies in the world. And recently, our solution is part of the semi-finalist in the prestigious $101 million X Prize competition, which is around improving health span. So it's really interesting to have this amazing group here together, the committee, where we will talk about how AI and all the amazing tools are going to make the life of physicians very, very different. Can we go to the next slide, please? So as we know, right, we now have infinite information on health. Every patient is either on Google or now using their favorite chatbots or LLM tools to figure out about health. And even after so much information, we see the population is only more unhealthy. And you all know the statistics of rising obesity rates or chronic conditions and mental health issues compounded with all this health information is not really solving the problem. And next slide, please. You will realize that the reason this is having a challenge is because we believe that health is not just an information or access problem. We have the best of the physicians, we have the best of the technology and diagnostic tools as well as therapeutics. In spite of that, people continue to lead unhealthy lives. The way to think about it is that the cigarette pack tells you don't smoke, it's going to cause cancer, but people still do that. So it's really a problem of motivation, not just information. And now the goal is how can physicians and the healthcare system use these tools, which are effectively used by the social media companies to engage people for not the right reasons, but how can we use this to engage people around their health? Next slide, please. So, and this problem is even more compounded because physicians now, people are walking into their doctors' clinics with all kinds of wearable devices and Whoop and, their Aura rings and have so much data. And at the same time, physicians have almost 350,000 point solutions, siloed health apps, with most of the data being unlinked and flooding EHR boxes and unbelievable physician hours. And what's really happening is that as healthcare moves from a, a primary to a reactive and now to a proactive approach, it's important that all this data becomes accessible, and not just accessible, the data also can be processed and analyzed. Next slide, please. And we all know that the world, and especially the US, chronic conditions contribute to 90% of the healthcare spends. And these chronic conditions not just require medication, this finally requires guided care rather than episodic interventions. And physicians are now increasingly being seen as a guide in the patient journey than just somebody who was kind of episodically making intervention. So it really has to become longitudinal and become from a transactional relationship to a much more longer, deeper relationship. Next slide, please. And here is where what we are calling, and popularly a lot of people are referring to as the Internet of Health. And now the data, the amount of data which is flowing in. Previously, the data was restricted to just hospital records, which was largely provider centric. Now, consumers are having all kinds of wearable devices. They have their own lifestyle data. They have their medical data. They have their fitness data. They have their doctor notes. Imagine if all of this data, both qualitative and quantitative, can lie in a data lake, which can securely then, using AI models and a variety of other tools subjected to privacy regulations and HIPAA, it can unlock some breakthrough technology when it comes to medical research, insurance underwriting, and personalized medication. Not only that, I believe that this data can also unlock food and nutraceutical development, because currently all this data is lying in silos and the doctors and the physicians don't really have a common view of this. And here is where, next slide, please. And here is where I think the whole technology is going to, especially in the world of AI. I'm sure this is a question every physician is asking, every healthcare system is asking, that how does one leverage the Internet of Health and AI? And we have been doing extensive work in the UK with the NHS. We are working in the Middle East with several governments. We also have presence in India. And what we are seeing is the new model of PPP, which is using a good AI model, and there are a variety of them, combining that AI model with wearable data, healthcare data, and even medical records. You can make healthcare predictive. And once you are able to make a prediction, like we see this person is going to have a very high degree of probability of getting a stroke or a heart attack or can turn type 2 diabetic, we can then personalize their pathway, and that personalization can be implemented, and hence the system becomes preventative. The best example I give here is, imagine your self-driving car. The AI technology in a self-driving car is designed so that the car never crashes. It's not designed for the car to crash and then self-heal itself. Similarly, the healthcare system of the future will be designed to prevent all these conditions to compound into a serious health issue and predictively make sure that does not happen. Of course, there will be solutions once you fall ill and once you come into the clinical system, but I think largely AI will be used on the preventative side. Next slide. And here is where I think that, if you look at the new framework, that how can physicians with data integrations, AI assistants, can really think about how they are going to, in the world of gaming, level up the consumer or the patient journey. And I believe that's going to happen with gamification, AI assistance at all levels, and integration with healthcare records. And that, combined with a framework of improvement of sleep, nutrition, fitness, cognition, and happiness, leads to improvement in health span. So I think the core metric is not just about how long you live, but how healthy is your quality of life. So health span becomes the North Star metric, not HbA1c or any of those other biomarkers, which are mere indicators. The final thing is, can you live a long and healthy life? Next slide, please. So in conclusion, all I have to say to this amazing group is that I think wearables, data, and gamification, which solves the problem of motivation, will lead to a very important thing. That is an engaged patient, just the way people engage with apps like Duolingo, which has become one of the biggest learning app. I do believe that the future patient engagement platforms with their doctors and clinicians will have gamification, engagement, and motivation at its core. And this will lead to better outcomes and improve physician efficiency as well as happiness for the entire ecosystem. Thank you very much.
Thank you, Vishal. So we are saving questions from the committee until the end of all presentations, but I know there's some that we'll want to follow up on. So next, we're glad to welcome Mr. Trevor Berceau, who's the Director of Patient Experience at Epic. Trevor, please go ahead.
All right. Hey, folks. Thank you very much for inviting me here today, and Vishal, thanks for that overview as well. My background, I'm on the R&D team here at Epic, and I have spent the last 18 years designing software to help clinicians and patients across many areas of healthcare. So from the hospital floor and the ICU to the emergency department, the OR, and now I lead the teams for MyChart and the patient experience products, really looking at how do we extend into the patient's home to empower patients as people to just better manage their health and healthcare. Next slide, please. And one of the things we've seen across our customer base is that patients are engaging at scale when given the opportunity. We have almost 200 million active users on MyChart, and they logged in over 6.3 billion times in the past 12 months. That shows a tremendous appetite from people to have that level of engagement and control of their health and healthcare. What we've seen along the way, digital tools can and do improve the patient experience and outcomes today. And the key is really designing care models that take full advantage of the digital tools that are available. That innovative care models are built when you have that combination of people, process, and technology, but really led with that clinical viewpoint. Next slide, please. Want to share just a couple examples of how this plays out. One big one is looking at how care in the home has been enabled through technology today, providing more continuous guidance for patients rather than that episodic care that would only happen when the patient's in the clinic with the provider. Organizations today have built care models around this and shown some pretty amazing outcomes. And there's really two pillars, I think, that enable this. The first is to continuously collect and understand key data coming from patients at home, whether that's home device data automatically filing in, or patient-reported outcomes where they're letting you know how they're feeling and how they're doing. And then the second piece is letting the system do the upfront analysis to identify which patients need intervention. And that intervention could be first just asking the patient to do something a little bit different, and then, if necessary, escalating to a member of the care team who can proactively reach out to intervene. And we've seen plenty of examples of this across the community. Just to zoom in on two, UCLA looked at their postpartum hypertension patients after they went home from delivering a baby to reduce readmissions and ED visits by 75%. And Ochsner did a similar thing, looking at their chemotherapy patients, looking at how can we keep track of how they're doing every single day throughout this treatment. And they saw a 33% reduction in ED visits and admissions. So these are huge in terms of outcomes for the patients, but also for the healthcare organization and the overall healthcare delivery system in terms of reducing total cost of care. Next slide, please. The other area I'll call out is improving education along the way. Just-in-time education can be really powerful in terms of giving the right bite-sized piece of information to patients at the right time, rather than giving them a 20-page handout and hoping that they remember to look at that right page when it becomes relevant. We've seen this improve experience and patient understanding, and therefore their actions and outcomes. And again, just a couple examples In the hospital space, groups like the Christ Hospital have seen significant improvements in their patient satisfaction and education scores. And then NYU Langone Health, looking outside of the hospital at longer patient journeys like surgery, saw, again, significant improvements in patient understanding and preparedness for those procedures. Next slide, please. Now, this is obviously great for established care journeys like a surgery, but there's a huge opportunity for technology to also help patients adhere to the plan that they discussed with a doctor during a visit. And like Vishal said, I think that it's not an access to information or a knowledge problem. A big part of this is behavior change. And traditionally, those instructions that were discussed are often just free text in a note or an after visit summary. And then you've got to remember to go back or actually use it. But now groups like Rush are using AI in MyChart to extract those follow-ups and turn them into discrete, actionable reminders. So it's easier for patients to adhere to that plan that they discussed and agreed upon with their doctor. Next slide, please. And the other thing that we're looking at, really excited about looking to the future of AI in healthcare, is, well, that just-in-time education, like we talked about with NYU or the Christ Hospital, is tremendously helpful. There's not a single video that can answer every question that every patient might have, which is why we've been working with organizations like UC San Diego to study what happens when patients can just chat with an AI assistant in the context of their chart, doing things like answering questions with not just general knowledge about what does that test mean, but with the context of what the provider put in their note regarding what they're looking for in their plan based off of the results, or other diagnoses or medications on the chart that might impact that value. Next slide, please. Now, those are just a couple examples of all of the different things that patients and healthcare providers are doing with MyChart today. There's a ton that patients can do themselves. Obviously, MyChart is what I know best, where I've seen a lot of these outcomes, but we've also built a robust ecosystem for patients to connect their home devices or other apps. On one end, that means making it easy for patients or device vendors to feed information into MyChart and into the EHR for patients and providers to use. On the other hand, that also means patients being able to bring and connect their own apps if they want to get data from Epic or from MyChart and use it in another experience that's more tailored to what they're looking for at that point in time. And our focus here has really been on industry standards like FHIR APIs or common data sets like USCDI to make it easy for app developers to connect and deploy those other technologies. If you go to the next slide, you'll see that this is working. We have real world adoption today at scale. Right now, over 850 different patient-facing apps are live across the Epic community. And across those apps, we've seen 500,000 of them authorized by patients and over 2 billion FHIR API requests made by those same apps over the course of just the last year. If you go to my next slide, rounding all of this out, I think certainly a tremendous amount of things being achieved with MyChart today, but regardless of the technology, I think there's 3 key strategies that are needed to drive change in innovative care models. First is that those innovations do need to be care model driven. They should be led by clinicians in partnership with IT to understand how tech can support different models of care. Second is, in order for it to be adopted, it needs to be easy for clinicians. Usually this means things like inline and workflow, and then having the system summarize key insights and present them proactively, rather than hitting providers with yet one more fire hose of data that they need to figure out how to make sense of. And then third is simplicity for patients is also key. One of the things that we have seen be tremendously helpful with MyChart is that it is that single app that they can use to manage all aspects of their journey in one place. I think the more that we can roll things up and make it simple for patients so they're not trying to go between 4 or 5 different solutions, the more successful we're going to be. And with that, I will wrap it up and turn it over. Thank you.
Thank you, Trevor. So next, we're pleased to welcome Dr. Pradnya Bhattad, an interventional cardiologist in Minneapolis, Minnesota. Pradnya.
Thank you very much for this opportunity. Good afternoon, everyone. It is an honor for me to be speaking with you all regarding various tools to enhance health literacy and patient empowerment. I'm trained in internal medicine, cardiovascular disease, and interventional cardiology, and recently working on developing tools to basically have a direct patient and provider accessibility on more of a digital platform, which is coming up soon. Next slide, please. We'll get started. Next, please. So patients often have a lot of information gaps, which is not necessarily from the lack of available data, but it's that they're not able to navigate the health system effectively. They may have limited understanding of their diagnosis, of their treatment options, about medication instructions, about when to call for help. And the tools, the educational materials are basically to empower them to understand their health conditions better, to understand what treatment options they have, what healthcare settings they can access, and do they need care in what particular system, what different kinds of providers they can go to, what are their treatment options. Basically, they need to understand their condition, get not only directed treatment strategies, but also should understand the risks, benefits, and alternatives to what they are being told, and tailored patient education, which is not one size fits all. This is something to empower the patients so that they can make a shared, informed decision, which can improve health outcomes, to reduce unnecessary testing, because there is a lot of defensive medicine practice which utilizes a lot of healthcare resources, which can be minimized to a great deal, which I think it's creating a lot of healthcare junk in the background, which is not helping our patients at all. And if we clean up that and reduce that unnecessary testing with the goal towards improved patient autonomy so that they are more actively involved in their own care. That's the main goal in terms of patient empowerment. Next slide, please. There are several digital tools in the current times, and we must acknowledge that these are some of the strongest tools that we have than we have ever had before, especially reaching some of the most remote rural areas where healthcare accessibility is a big concern, even in the most developed nations. There are several tools such as telehealth and mobile applications, patient portals, online resources, and personalized health coaches and navigators. Next slide, please. With the telehealth, it's the strongest mode of digital tool that we have, which has the ability to reach some of the most underserved populations. It is not only for a regular virtual visit, but ongoing follow-up of chronic conditions. The vast majority of conditions that we have are a lot of chronic, and to support that for regular follow-up and to make sure the goals that we develop with our patients together so that they reach their healthcare goals are actually there in line with that. I think those are some of the most important things for which in the underserved areas, it is very, very unlikely that rural populations will seek regular chronic follow-up. And telehealth can have this ability to encourage active participation in their own healthcare, better understand their care. Sorry about that. Better understand their own healthcare and encourage active participation in their own care, increasing patient autonomy. So this is more efficient from a provider standpoint, and this can be more efficient in terms of their travel times, the costs, the continuity of care. These are all minimized, and we are able to provide patient-centered care and improved outcomes. Next slide, please. Various mobile health applications can also be used not just for telehealth, but several health metrics can be tracked. For instance, it's not just about the vital signs and activity levels, but there are already a lot of applications. For instance, electrocardiographic data, ECG data, heart rhythm monitoring can be done without the need for event monitors. A lot of times common arrhythmias are detected with just these mobile health applications, and these can be followed up and can be treated accordingly, can be used to encourage them for healthier habits, and through virtual follow-up to support the behavioral change and manage these chronic conditions so that they're more active in their own wellness. Also, these mobile health applications can provide resources on various treatment modalities to understand it, because it's very alarming when I see patients oftentimes who do not understand their own health conditions. For instance, they might be taking a blood thinner and they don't even know what they're on it for, what the risks are, benefits are. This is just an example. And I've seen patients who have been on certain medications for 20, 30 years and they have no idea what they're taking it for. All that I hear is, my doctor told me to take it and I'm taking it. And then they just keep taking it for years and decades. And that just increases polypharmacy, and there could be a potential for decreasing that. So the goal has to be to eliminate excessive junk, which is not current, which is not up to date, and to have the data that is needed for very specific patient education. And for this, provider training is important as well. Next slide, please. So patient portals can do the same as well in monitoring health metrics, lab results. For instance, you're monitoring certain, for instance, aortic dimension, and close follow-up through those besides regular administrative tasks, but related to their appointments, medication refills, for instance. And in the past, I remember when I started my training, patients were not able to access their own medical notes, for instance, which eventually changed, and now they're able to access their own notes through the patient portals, which is a great change in the last few years, increasing the transparency. But there can be a more tailored component wherein the transparency in patient care, for instance, patients should have information about their billing system, how the insurance works, how much they are going to be billed for a certain procedure or a certain test. Even the providers are not very well equipped to understand how that happens, and neither are the patients. So there is a huge gap in providing that clear transparency onto how the billing process works, what would be the upfront estimated costs, because nobody really knows what the rough average estimated cost of a certain healthcare would be, or for a certain medication would be. If I am prescribing somebody a medication, but I do not know what it would cost to a specific patient, and it changes based on everyone's insurance plans, I think having that key transparency can be very much cost effective to the entire economy as well as to the patients, and could reduce unnecessary costs. And patient portals do have the ability to incorporate these and further encourage active participation. Next slide, please. There are several additional tools besides what we discussed. There could be health literacy assessments and peer support groups and patient navigator resources. But some of the most important and most impactful would be if the providers undergo health literacy training, in which the healthcare professionals, the providers, are educated to help impart patient education every single time they see them. Next slide, please. The most important thing is if they're able to clearly communicate in an unbiased way, provide the patients with the most transparent information, the most complex information, can eliminate misunderstandings and better make the patients understand, very well inform them about their conditions, about their treatment options. And if they understand their treatment options, they can take active roles in what they want. Oftentimes, if I have a patient who is referred for a certain heart catheterization procedure, and if I am explaining them, these are the risks, these are the benefits, these are the alternatives, and it doesn't take me too long to explain this, but what happens is I'm surprised. Oftentimes, patients are not even aware of all of these by the time they come and see me and they're ready to be going for a procedure, which does have some life-threatening risks. And I'm alarmed with the fact that how uninformed patients can be. And it just takes some simple disclosure, key transparency, complete transparency in the process, and conveying more complex information in a very simple format to educate the patients that they understand. Because if I understand something, then I can make a complex decision for myself. And that is what we can call as a shared decision making and not a one-sided decision making. And that can give the patients the most autonomy, and that can improve patient satisfaction, and that is how they will know what they need to follow up on their own care, because it is their patient's health care ultimately, and they have to take a full lead in this, and we are supposed to help them every step of this way. And the most important part starts with this health literacy training, which I think is the most simplest form we can start with. Next slide, please. And some of the most useful information in this would be to create certain accessible and relevant materials which are tailored to our individual patients, that can be used instead of just importing. This has to be a two-sided conversation between the patients and providers, and a long-term follow-up wherein there should be some virtual or telehealth or digital platforms to be developed, in which the patients and providers can directly communicate, hey, I saw this result in this particular test, what do I do next? This should be directly approachable to the physicians. There's no reason to not, and should initiate a direct conversation. But there are too many uh, obstacles in between that flood the providers' charts, their inboxes, to the point that they may mute them and they may not ever get back to them timely as it is needed. So if we are able to eliminate the junk, have a focused approach, and uh, to develop a direct patient provider communication and long-term follow-up with minimizing the junk in both the patient as well as the provider's boxes, I think that is going to be the most effective communication strategy, and the organizations can improve patient outcomes and satisfactions to their best. I thank you all very much for this opportunity.
Thank you, Pradnya. So last on our panel, we are happy to welcome Dr. Ricky Bloomfield, who's the Chief Medical Officer at Aura. Please go ahead, Ricky.
Thank you so much, and thank you to Vishal, Trevor, and Pradnya as well for your comments. +1 to everything that you said as well. So a little bit of background about myself. I'm the Chief Medical Officer at Aura, which is a smart ring company. And my clinical background is internal medicine and pediatrics, as well as a board certification in clinical informatics. Prior to joining Aura about 6 months ago, I led the clinical and health informatics work on the health software team at Apple, where I worked on a number of the things that Trevor actually touched on, including sort of at the dawn of the Fire API ecosystem. I had spent some time at the Duke University Health System building out an API there before there was formal support for Fire APIs, or before most people knew how to pronounce Fire. And saw it as a real way to lower the barriers for access. And I had the opportunity to go to Apple, where we built the first app to use Fire APIs at scale, and we're able to work with the major EHR vendors to test and validate these APIs initially. And we're able to grow that from, I think, 13 health systems when we launched in 2018 to over 10,000 unique health systems by the time we left, all with standards-based APIs. And one of the reasons that I'm most proud of that effort is because not only did that help to kind of smooth the path for an organization like Apple to access, but also because it's an open standard, it helped smooth the path for everyone. And the 800 plus apps that Trevor showed right there to be able to access. And at the end of the day, that's what we have an obligation to do, which is to help more patients access their data securely and privately, so that they can have and be more empowered to improve their own health. And also at Apple, Apple is a company that produces hardware, and the Apple Watch had some of the first features that are regulated. For example, atrial fibrillation as a regulated device. And at the time, there was a lot of, I think, consternation among the clinical community. And, I spoke with many clinicians that this would result in just a wave of misdiagnosis and worried well. And while there will always be some amount of worried well, I think in general, most physicians now that I've spoken to have either directly, treated someone or have a family member or know of another, patient of a fellow clinician who has come in with an alert from one of these, many medical devices now, wearable devices that have software as a medical device, FDA cleared features, and that it was true. And this is what I'm most excited about in the future is how can we, with these devices that are the most intimate devices you can have, that's in contact with your skin 24/7, how do we use that as a force for good to be that check engine light for your health, or the guardian angel to find these things that otherwise would not have symptoms, not have obvious symptoms? And how can we help alert someone to the risk of these features earlier so that they can go in and get checked out? And of course, do that in a way that is evidence-based, with the right and appropriate sensitivity and specificity, in order to make these tests powerful so that they can improve health at reduced cost. So speaking about Aura, our goal from the beginning is to give everybody a voice. And Aura was a company that was founded 13 years ago and was really focused on sleep initially. And the goal was, how do you make a device that can be with you 24/7, that you don't have to charge at night, so that you can get the highest quality data to help someone understand their sleep? And of course, sleep is something that impacts every aspect of our lives. We know if you don't have good sleep, we're not going to have a good day. And we know that there are many, many different things that can impact sleep. But we actually grew from sleep into measuring many other things using similar sensors to a device like Apple Watch with a PPG, motion detection using the accelerometer, temperature detection, and can put these together to actually measure a number of different things. So if you can go to the next slide, just for some context and background, now there are over 50 different metrics that the Ring can measure. And unlike early versions of the Ring that lasted a couple days on a charge, the latest versions in a very small device can last up to a week. And what that means is the opportunities that you have to sense and potentially intervene, especially for individuals that are at home outside the clinical setting, is really, really powerful. And we've seen incredibly high levels of engagement that I was very skeptical when I first looked into the Ring. But we found that individuals wear the device 23.5 hours per day. They open the app multiple times per day. And that's true because they see the direct benefits that it helps with them. Just as one example, even though the device was not intended to have this impact, we've seen that for many, many people, once they start wearing the Ring and measuring their sleep, they've seen the impact of alcohol consumption on their sleep. And for some people, just a single drink will disrupt their deep sleep. It will impact their HRV. And while they may not have felt great in the morning, they've never been able to quantify that. So being able to quantify the impact of alcohol on sleep has resulted in many people significantly, cutting down or completely stopping alcohol altogether. And that was a surprise to us. That wasn't something the device was designed to do, but it was designed to be very, very accurate, and based on a foundation of science. So when we heard of these things, it wasn't surprising to us, because of the amount of validation that we put into the device. But it shows that shining a light on additional information in the right way that is consumer centric can have a dramatic impact on health and health outcomes. Next slide. And just to talk a little bit more about the foundation in science. See, the slide hasn't switched for me yet. Maybe there's a lag on my side. I'll talk just a little bit about the sort of scientific validity of the ring. So we have over 30 PhD scientists that oh, there we go. 30 PhD scientists that work on this device to not only build the features but also continually to validate the features. And there are over 170 peer-reviewed studies out on this. I just lost the presentation on my end. And this is really important for us because it's not just about creating an engaging experience. It's about making sure that it's accurate and that it is founded on science. And so this is something that we could dig into more if there's interest. One of the latest studies was from the Air Force Research Labs. We do a lot of work with the DoD, and they are very interested in using this device to improve readiness of troops and resilience and reduce stress and detect burnout among the troops. And this actually came about initially through the Navy with a couple of unfortunate accidents that happened in 2017 where there were collisions of Navy vessels. And there were many sailors who died in those accidents. And it was traced to fatigue and burnout. And so the Navy is very interested in understanding what they can do to, number one, measure that. And number two, once they have that information, how do they act on it? And so other branches of the military, including the Air Force, have had an interest in the same thing. And so the Air Force Research Labs did a test of some of the major wearable devices and found that Aura, Generation 4 was the most accurate for resting heart rate and HRV compared to all the other devices. And that's really important because these are the metrics that can serve as a foundation for a lot of the stress and resilience information that comes from it. And talking about the accuracy, if you go one more slide. To the next slide. And so, as I mentioned, the device is built for accuracy. So heart rate, 99% accurate compared to ECG. Same thing with body temperature, heart rate variability, and sleep tracking. Sleep tracking is compared to the gold standard of an overnight polysomnogram. And again, this is important for everything else that we would like to do, especially for caring for patients at home. Next slide. Just to briefly talk about some of the use cases we've seen. I mentioned burnout already on the DoD side, but also I'm very interested in burnout across a number of areas. And so DHA is also very interested in studying burnout among clinicians. And understanding how do we help the clinician population, again, detect burnout and stress and also intervene sooner before it becomes a crisis. And we know that across health systems today, burnout is a serious issue that was magnified from COVID and a lot of the work that happened there. And burnout is one of these, unfortunately, a negative cycle where the more clinicians you have burnout, the more that exit their profession, and then the worse burnout becomes for those that are left. And we also know that there is going to be a shortage. There's already a shortage of clinicians, but that will only become magnified. The AAMC actually did a study last year and showed that by 2036, the physician shortage will be 86,000 clinicians. And that's just in the US, not including the rest of the world as well. Also talking about primary care, we have hundreds of clinics that have implemented this in their clinic and very interested in understanding how these devices can help them make better decisions. And again, because we want to move from this break fix sort of reactive system of care to something more proactive where we can focus on prevention. And the best way to do that is to improve our understanding of the 99 plus, at least we hope it's 99 plus percentage of time that patients spend outside the care system. We don't want our patients to spend more time in the care system. We want them to be at home living their fullest lives and having, maximizing their health span, the number of days of their lives that they are healthy. And so working with clinics on how to incorporate that data into electronic health records, how to incorporate that in a way that uses open standards that were talked about before is really, really important. And that also goes into chronic care management. So we've partnered with MA plans, including Essence, an MA plan in the Midwest, and they are offering the Aura Ring as a covered benefit now because of the high level of engagement that they see. And their interest, of course, is if we can improve engagement, they can improve health outcomes. And these are 65 plus, not what you would call digital natives. But the uptake has been very, very strong to the extent that they want to expand this. And this includes the ability to, not just wear the device, but also to share that data back into the health system so they can take action when there are metrics that are off. You could imagine a CHF patient or a COPD patient that are having an exacerbation. They want to prevent those readmissions, and they see this data as a way to help close that loop. Next slide. I believe this is the last slide. Finally, we understand that it's not just about measuring the data at home and helping users to access that data themselves, although that is a major part of it. What we can do to empower users with their own data. Unfortunately, we've seen, especially post-COVID, that many individuals are opting out of organized healthcare. They are becoming they're losing trust in general, and I worry that could become a crisis, that we have more and more people that only go when they absolutely have to, when there's something that is obviously wrong. And this means that our opportunity to engage meaningfully in prevention is diminished, because prevention is something that really requires engagement with the health system, with those that can help you, understand what vaccines you need, what screening tests that you need. And the more that we can do to help surface some of these risks earlier, and then encourage people to, enter into the health system again to get the care that they need, is I think a growing there's a growing urgency around something like that. So what we want to do is partner with organizations that can, number one, help us to measure things. So we partnered with Dexcom for the over-the-counter Stelo device to help people understand their glucose trends over time and how it relates to their meals, so they can improve their diet, improve their overall health. I wore this device for the first time earlier this year, and I learned how big of an impact a late meal has on both my sleep as well as my glucose. And as a clinician, those things should be obvious, but we're not taught all of these details in medical school. So it's really interesting to start to see how some of these devices have opened up our eyes around the impact of some very, very basic daily routines. And then we also partner with organizations like Maven, which is the largest virtual clinic for women and families, to help our members who are using the device for cycle tracking or for their, to manage their pregnancy, that when they have questions or concerns, they have someone that they can turn to. We know that we can't do everything for those members, so we want to be able to have a streamlined way for them to get access to trusted professionals to help them take the next step on their journey. Thank you very much for your time and attention, and I'll turn it back over to the team.
Thank you, Ricky. And thank you to all our experts for those great presentations. So next, we're going to open the discussions to our committee members. At this time, PTAC members, feel free to flip your name tent up if you haven't already, although I see many already up. And for our virtual committee members, please raise your hand in Zoom. In the interest of ensuring balance and try to get through all the questions that are up here, please try to keep your answers to just a few minutes so we can get to all of the questions. I think I'm going to start off with Lee.
Sure. This really, I guess, is directed to Trevor and Ricky, but I guess I'd love everybody's thoughts. And I come to this question having been a primary care leadership operator for 25 years before I flipped to the plan side. And so I must say I've got a challenged relationship with activities, and it's the unfortunate reality in the world that there is both waste and abuse as well as fraud at times, and serves an important role. But we certainly want to lean into using data and HIT to transparently empower both customers and support providers. And so I'm just wondering if you can unpack a little bit for us things that maybe Epic is doing, working with partners or piloting, using the clinical data we have in health records to automatically meet transparent, evidence-based clinical decision-making guidelines and serve health plan partner needs up front instead of it being an administrative process, driving it from the provider side. And then ask Rick, if you ever thought about, is there any chance that patient-provided information could be paired in that same space? I could definitely see, we've got guidelines that tell us which patient can have a home sleep study versus an in-lab sleep study, and I suspect that information coming from the ring could differentiate that up front and again remove some administrative burdens. So love your thoughts on that.
Yeah, great question, and I can start. We have been working very closely with many folks across the Epic community to look at how do we kind of standardize some of those clinical programs and clinical pathways that they have done. Often this looks like working with an organization who has motivated clinical and operational leadership, or sometimes working with our steering boards focused on specialties, whether that's cardiology or pediatric medicine, any of those specialties, to say, okay, what can be done? What are the types of innovative care models that you would want to stand up? And then how do we put together all of the technical pieces and parts to make it happen? And that could be for something as straightforward as looking at a CHF patient post-discharge, right? Obviously, for congestive heart failure, one of the big warning signs is if weight is going up for fluid retention, and that's often a warning sign that you might be looking at someone coming back to the ED or the hospital. So being able to get it protocolized, so as you send these patients home, you send them with a smart scale or the ability to connect to a smart scale that they already have at home, feed that data in, and then the algorithms can look at it to both prompt the patient to take additional action, as well as alert a care manager or another person at the organization to then reach out and see what do we need to do to prevent this from turning into a readmission. So we've done a lot to try and kind of protocolize and standardize some of those best practices. Here's how you put it together. And then, of course, all of the data is there from a documentation standpoint for here's the data sources that led to this kind of clinical, this clinical review that then led to this prescription adjustment or this telehealth visit or whatever that follow-up may have been. And then we have been doing more as well to look at how do we package all of that up and kind of collaborate on the payer side as much as possible to say, hey, here's all the information that you need that outlines the clinical decision-making that went into it and why it should be allowed. And honestly, our goal, we've been starting to do more work with payers in recent years as well. The goal being looking at where are some of those forms of waste where can we get rid of prior authorizations? Where can we say, hey, we can make these prior authorizations applicable in much smaller amount, or where a prior authorization is needed, how do we automate it as much as possible, or kind of get that turnaround as fast as possible? So we've been looking at it all the way from the clinical program side to the how does this get communicated and documented side. I think that communication between payers and providers remains a challenge in many spots, but it's something where we are starting to see some progress and have a lot of optimism looking forward.
I would just briefly add to that. The short answer is yes to your question. Those absolutely are things that we are looking into. In fact, the early work that we've done with Essence, this MA plan in the Midwest, they're a payvider, so they have a number of clinics that they are overseeing as well, many of whom use Epic. And they're very interested in getting that data into their clinical workflow so that they can action on that data as easily as possible. In fact, some of the early things that they're interested in are nighttime breathing disturbances, including looking at sleep apnea. So the use case that you mentioned is exactly what we would like to try to improve so that you can try to triage and use resources more effectively. At the end of the day, they want to improve health and save money, and that's what patients want. That's what we want. And so if we can do that with a relatively inexpensive home-based device and help them connect with their clinician in a way that allows them to get the right information to the right doctor at the right time to make that decision, then that's a win all around. And so we're already seeing a lot of progress on that front and are actually building a web-based clinical dashboard that can integrate right into the EHR with a single click so that they can view that data, again, using the open standards that have been developed over the past decade.
Thank you both. Jay.
Thank you. Great presentation. A couple of questions, one for Trevor, and it's really specific, and then a follow-up, which is kind of related to Ricky. And that is, in the outcomes you showed, Trevor, at Christ Hospital NYU, were you able to break it down by line of insurance, whether they were commercial insured, whether they were Medicare insured, or whether they were Medicaid insured?
I do not have that breakdown. Those were the satisfaction scores that they showed were from the HCAHPS data that they were getting from their patients. We can follow up with them to see if they have that, but I don't have that by.
All right, I was just curious. And then somewhat related, Ricky, OR started out as a direct-to-consumer purchase. And it's interesting to hear that now a Medicare Advantage is going to cover it. And one of my concerns, this is kind of for everybody, but it really crystallized with OR is, how do we make sure that digital tools don't become another healthcare disparity? In that, that everyone's got equal access to these tools. And I'm just curious, what OR's approach is going to be, and and across for everyone as we consider, how we're going to leverage these digital tools, that we really be able to need to offer them across the healthcare continuum, for all payers, quite frankly. So I guess, Ricky, I'll start with you first.
Yeah, that's such a great and important question. And first of all, I would say that Essence has chosen to cover this themselves. I don't want to spread misinformation that MA plans generally are covering this, and so they're willing to take the risk as an innovative plan and see how it works. And so far, they've been very happy with that. And the goal, we can't call it a success until we've actually measured it. And that's the end goal. Can we measure not only improved health outcomes, but also cost savings? We have to do that before we can declare victory. And so I think that's really important, foundational point. And I'm sure you all would agree with that. And so we actually have a director of health outcomes research that joined, that is helping to lead these efforts to study and publish transparently, these results. At the same time, we recognize that these devices can be expensive. And so we're working all the time to reduce, to produce these at lower cost. We also are working on initiatives to help compensate for these through FSA and HSA plans. We also launched an initiative earlier this year where is our first partnership with a company that helps manage the ICHRA plans. If you're familiar with those, it's a newer individual coverage plan as more people are opting more employers are opting to share dollars directly with individuals versus covering insurance plans or giving them the option. The ICHRA plan is one of those options. But at the end of the day, we need to show outcomes and ultimately show that the cost savings are greater than the cost of the device so that these can be covered for everyone, so that the benefits are available to everyone. Interestingly, what we've seen, and you've probably seen a similar thing, is that if you look at the demographics of who owns a smartphone today, almost everybody, and so it comes down to, is this device useful for you? And for a lot of people, the evidence around a wearable is questionable, whether it's useful for you or not. And so I think as we start to see that change, and as we start to see more and more devices that are FDA cleared, that are proven with the science to be beneficial, we'll start to see that calculus change over time.
Thank you.
You're welcome.
Did any of our other panelists want to answer? Vishal, I saw you unmute.
Yeah,
You don't have to.
I just wanted to add something because we work with several governments across the world, and accessibility is a very important question. In India, we have extensive experience on that, and similarly in the NHS, we work with several counties which are having population which are at a very different socioeconomic level. So what we are seeing is it's not just about wearables. It's actually creating community-based digital tools where there is, even at the clinical end, when you enter a clinic itself, there are tools which are available and devices which are available, which can be used for remote testing, or they could be people in the field who are enabled with these devices. So a lot of times, when you look at devices, they are not all just personal devices which people kind of carry and own. It's also the community-based testing. So think about it that you are able to cast a much wider net in the healthcare system to catch people early on versus waiting for them to have a symptom, fall sick, and then come into the system. So it is like having a digital surveillance network which kind of keeps expanding in these communities. And as you identify people at risk, you kind of zero in on to them. So that is an approach which we've been taking very effectively.
All right, I see Krishna, then Walter, then Larry. Krishna.
Hey, thanks, team. Great work on this. Mine's maybe for all of you. I mean, we're obviously seeing this like proliferation of apps. Obviously, Trevor, you're the 860 something number. That's just the Epic Store. Clearly, there's more in the Apple App Store there. So clearly, it provides consumer choice. Obviously, more competition. So we like that part. But I also hear from the provider community just adds more sort of noise to the mix, and teasing out signals is a challenge there. So the second half of our sort of theme meeting, which one is on empowering consumers, the other is on supporting providers. I'd love your perspectives on like how are you approaching the provider support piece so you can surface up more signals from obviously a plethora of data that'll be collected by all these apps.
So I'll go first on this. So you raised a very important point, Krishna. I think what has happened is that the world has got filled with point solutions. And on one EMR system, there are now 50 or 100 point solutions which are sitting, each operating in a silo. This was all good when it was clinical solutions. When a person was within the clinic, the doctor could kind of connect the dots and make still decisions. But now, as the care is becoming more remote, imagine a patient who is having a diabetes and then is also having a heart disease and is also having mental health challenges. They are all connected, but the solutions don't look at it as connected problems. It could be connected to your sleep, for example. So what we are seeing is unified solutions, which are almost anti-point solutions. And now, especially payers who are controlling the purse are saying that I want to have a 360-degree use and view of the data and then get insights out of that. So just think about your banking app in a way. Previously, banks had a different app for savings account, a different apps for credit card, a different app for different things. But now most of the banking apps and fintech apps are combining into a unified interface for the consumer. The same thing is what we are seeing happening in the healthcare domain, both for the provider as well as the patient, as well as the clinician. They're all going to work on a similar workflow. And AI is then going to power each one of them with their own co-pilots. So that's really where the direction of what we see going.
I would add to that. I think that's a good point. And I think it's definitely a balance where one of the reasons point solutions exist is because there are many ways to solve the same problem. And at the end of the day, we want the best solution to win, and we want that competition in the marketplace so that you can have the solution that improves health at the lowest cost. From my perspective, the best way to mitigate the challenge of having so many point solutions is to continue to invest in interoperability. And that's something that I've spent a decade of my career doing. You've certainly seen the work that EHR vendors have done, like Trevor, highlighted here. And I had the opportunity to attend the White House for the MAHA event, where there's a focus on kill the clipboard and conversational AI agents and improving identity management at a scale, at a scalable way, so that you can break down the remaining barriers to true interoperability. And I think that's what CMS ASTP is currently focused on, ONC. And I support those efforts, because there's still too much friction in the ecosystem, and there is still, as we saw I think it was a couple days ago, additional action on information blocking. It's still harder for some individuals to access data when they want it at the point of care. I think the other thing that's also really challenging is it's become much easier to get the data out of the EHR systems. It's still the standards still don't exist to get the structured data back into the system. And so I know I've worked with Argonaut for many years. This is a project within HL7, which is the Health Data Standards Organization, to work to standardize how data can go back into the EHR. And I think that's a really important unsolved problem at scale. There are a lot of proprietary ways to do it, but ultimately having strong standardized solutions for both input and output are how you can take action with a number of disparate systems to maintain the competitiveness and the benefits from that, as well as getting the data to the right place at the right time.
Trevor?
Yeah, I would add, I really like to think about this in two categories. One is just how does the data get moved across the different systems? And Ricky, 100% agree with you. Also, very supportive of the work the Argonaut project is doing to standardize how do you get data across, because that's exactly the goal of those standard FHIR, USCDI, other definitions like that, is so that, well, most of our organizations will pick, these are the couple blood pressure cuffs that we use, and we will help you get set up with those. But if you want to go and buy a different blood pressure cuff, that can still connect through these standardized ways. And kind of the organization can provide a few, but still have the gates open for any that want to file data back in without needing to do work with every single blood pressure cuff that is out there. So 100% agree that we need to continue pushing forward the FHIR standards, the work of groups like the Argonaut Project and others. The second, you also made the point of just clinician burden about knowing what to do with all of this. And that's where I think the other big piece of the puzzle is really just the usability and display. And thinking back, Ricky, you also mentioned early on the Apple Watch and the concerns about, oh man, there's going to be this whole new fire hose of data. What are we going to do with it? Really looking at what's the clinical relevance of the different feeds of data. Almost no one is going to want to go in and look at every single data point that comes in. Maybe ahead of a visit, the primary care doc wants to see a summary of the trends. This patient has had hypertension. Is it generally stable? Is it trending in the right direction, the wrong direction? So being able to distill it down. Or conversely, the kind of, if they're using risk stratification or things like that, being able to see in general, has someone veered into a range where just based off of known clinical best practices, targeted algorithms, or new kind of generative AI-based models, we might want to explore them. So I think it's looking at, no matter where the data came from, getting it distilled down into simple ways to use it. And again, that needs to be handled at it. Is this for a primary care doctor ahead of a visit? Is this for a cardiologist ahead of their first consult with a patient? Is this for managing a panel of 10,000 type 1 diabetic patients?
Thanks, Trevor. We have about 15 minutes left for discussion. I think Walter and then Larry.
Thank you, everyone, for sharing your time and expertise with us. My question has to do with something that Ricky mentioned, which was kind of the evidence that these digital tools increase patient engagement, which hopefully will result in improved outcomes, both financial and clinical. PTAC is focused largely on the Medicare population, a bit older population, maybe not as digitally native than some of the younger populations. And even within the Medicare population, of course, we have the recently retired, just turned 65, all the way up to, my oldest patient is 107. And I'm just kind of wondering two things. One, what does patient engagement look like in the Medicare population with these digital tools across the kind of various age ranges? And then two, what are kind of the latest and greatest results in terms of patient engagement actually resulting in improved health outcomes with these digital tools? I know Trevor mentioned a couple of examples, I think primarily in a younger population. And maybe this can be directed initially toward Vishal and Ricky, and then anyone else who wants to jump in.
So thanks for this important question, because as we know that a bulk of the healthcare cost is concentrated on people as they age, and especially after they turn 60, that's where burden of healthcare costs really balloons, and this is a global problem. The way we are addressing this is at multiple levels. Firstly, if you look at a lot of interventions, especially in the UK or NHS and these kind of markets, it's all focused around people above the age of 60, and all our solutions are specifically targeting this population. And there are simple tools like even using very big fonts in your apps, all the way to having what we call very, very hands-on care navigators guiding them through the process. So there are some soft and hard tools which we deploy. But I just want to add another very important aspect to this. I briefly mentioned about the longevity X Prize. This is a solution we are working with, and there are several over, I think 40 people are now in the semifinals. This is a solution only for people above the age of 50 to 80. So what they are trying to do is design accessible solutions for people in the age of 60 to 80 and focus on cognitive biomarkers, immune biomarkers, and muscle. So based on these three biomarkers, they are literally talking of age reversal. And the kind of interventions we are talking about are largely behavior combined with personalization. So one of the key goals, apart from therapeutics, even as you age, it's really about not the one-size-fits-all model. It's about hyper-personalization. And I think now with digital tools, you can deliver the same therapy to the same person, but if you can personalize the experience, and this could be even going as a simple text message, the response is 8 times more with personalization. And we have seen that across markets. And that is one of the reasons why gamification as a tool is so important, because we are all used to be getting incentivized with behaviors. I'm sure we have all used Instagram and TikTok, and we can see how these interfaces are engaging people. So similar techniques are now used from a gamification perspective, and this is working across age groups.
Yeah, I would agree with that. And I would add that there actually is an actuarial study on the benefit of activity and activity trackers in the Medicare population. I actually just put that in the chat. If you have access to the Zoom chat, or hopefully the team can share that with you all. This was done a little while ago, but it shows that increased activity can result in lower cost or cost savings. But I would be the first to say that we don't have enough evidence for all of this, and we need to do more and invest in evidence. One of the biggest challenges is a pragmatic one, which is many of the companies who are creating wearables aren't necessarily incentivized to spend the significant time and money it takes to measure these things. We are, like, as I mentioned, we hired a director of clinical outcomes research. We're investing in this area. I feel like we're an outlier, but it's still early days, and it's going to take time for us to generate that evidence. but it's so, so important that we actually prove the benefit, not just in the general population, but specifically in the MA population. And that was one of the reasons we're really excited about the partnership with Essence and their MA plan, is so that we can measure this, so that we can measure the impact of early intervention on some of the metrics that we discussed before. And my hope is that over the next few years, more organizations will invest in showing the hard data on how this is beneficial, and not just talking about engagement numbers, which, it's always fun to talk about levels of engagement. And when that's all you have, that's what you talk about. But at the end of the day, we want to actually see change in outcomes like this study that I shared shows.
All right, Larry, thanks for your patience. You're up.
Okay, last of all, we heard from Abe earlier the word gamification. We've heard it a little bit from Vishal, but I would like you to expand a little more. It's more than just personalization. Your corporate roots started in the gaming industry, so I'd like you to elaborate for us. How is it deployed? What kind of success has the gamification component produced? And how scalable is it?
Yeah. Thanks, Larry, for this question. Just to simplify the world of gamification, imagine you are new to a game and you're given a very hard level. You will get frustrated. And then imagine if you are very experienced in a game and you're given a very easy level, you'll get bored. Now, that's what's happening in healthcare. We are asking patients to change lifestyle. And the doctor says from tomorrow you have to go on a 1200 calorie diet and exercise for 2 hours a day and walk these many steps. So while we have given them the right therapy, there is an imbalance between the experience level and the difficulty level of the task which we are giving the patient to do. The world of gamification understands this, and we are able to break these tasks into small milestones for which they are constantly rewarded. And this behavior induces dopamine. We then are able to pair them in groups and make them do activity which induces oxytocin. And we also are able to then engage with them and even do what we call group tasks, where they do things together as a group, which induces things like serotonin. So, and then of course, endorphins kick in when you are doing activity. So actually the gamification actually has a lot of deep science, and all the social media tools use these techniques exactly, but for, I would say, the wrong reason. They're using it for you to be addicted to using their apps and finally click on their ads. Now, imagine if the same tools which are used by the social media platforms to make you lazy are now used for you to engage a patient, to do a behavior which you want them to do, to adhere to the medication, to do their tests and talk to their doctors. So we are able to map out behaviors which we want to do, and then in a game design, incentivize, balance those behaviors, put the right counter behaviors, and put a framework which engages. We have done this now at scale at multiple healthcare systems itself, and systems are seeing a lot of benefit because now you are actually not having headwinds, but you are having tailwinds. I want to give you one example of a program we ran with gamification, and the outcomes were incredible. This was done for a group of diabetic patients, where in 90 days we were able to reduce their levels by 1.4 points HbA1c in 90 days. And the only gamification was, we told them that all the behavior you do compounds, and for every 1 point drop in HbA1c, you will get 1 gram of gold. So people were all suddenly competing for winning that 1 gram of gold, which was correlated to the 1 point HbA1c. And then there were multiple behaviors. Of course, this was we had put a paper out on this, but the example I'm giving you is that for doing all the bad behavior, all the junk food companies are rewarding you, or every time you go to Starbucks and have that latte, they are giving you stars and points, but that's not happening when we want them to do the good behavior. So that's really what, in a nutshell, if integrated well into the healthcare system, can be a complete game changer.
Yeah, I think it's such a good point about incentives and making sure the incentives are aligned for individuals. And one of the things that I've seen is that, especially when it comes to health, gamification can be really, really powerful. There is another side to that, though, and some wearable devices are focused on streaks, meaning you don't want to break your streak. It's more every day, and sometimes there are days when you shouldn't exercise, when you're sick, or when maybe you've overdone it the day before. So it's also really important to take into account, how do you find balance so that you are pushing when you should be pushing, but also holding back. And so I think that's something that the industry overall could do better, because it's not engagement in health shouldn't just be about driving more usage, but it should ultimately be in service of improving health. And sometimes those two aren't aligned. So it's really important to keep that keep that in mind. The other thing I would say is, when it comes to presenting data to the user, there are so many ways to do that. And the last thing that people want is to be overwhelmed with spreadsheets of numbers. And so one of the things that was really interesting to me, so we have a feature called cardiovascular age, where we actually use measure a metric called pulse wave velocity, which is a measure of large artery stiffness, large blood vessel stiffness, and that can correlate with the age of your cardiovascular system overall. And if I told you that your pulse wave velocity is 6.8 meters per second, that would probably not be very useful. But if I say that your cardiovascular age is 5 years older than your chronologic age, and other in your peer group, all of a sudden it becomes a metric that helps you understand where you're at. And when we released this feature, we had a number of people, both inside the company as well as externally on Reddit, saying that that was the trigger they needed to motivate them to start exercising again. Because knowing that their cardiovascular system was older than it should be, meaning your vessels are stiffer than they should be, made them realize, well, I want to be around when my kids graduate from college, or to see my grandkids. And it motivated them to take that step that they otherwise were not willing to take. That is some of the most powerful, ways that we can help people improve, is by giving them the motivation and incentive to change behavior. And fortunately, for something like cardiovascular age and pulse wave velocity, it's a modifiable factor, meaning once people started exercising, they saw that number come down over a number of months. And so seeing that number come down is some of the most powerful validation that you're on the right track. More powerful than any specific gamification strategy is understanding that you're getting healthier. That's what keeps people motivated. So finding ways to continue to do that and help people make the right decisions is an ongoing process, but I think there's a lot of promise there.
Yeah, so I just want to add one thing which Ricky mentioned about the age. So what we did is we took your age and we connected it to your avatar. And as you become healthy, your avatar becomes younger. So you become your own virtual pet. And what we saw that was, now suddenly you want to take care of this virtual pet. And as you become healthy, it kind of corresponds to that. And we have seen amazing interaction, and people are all wanting to take care of this avatar. And connected to that, we are just about to launch a blockchain-based reward system for health. We are calling it Proof of Health Protocol Universal Healthcare Token. We are hoping to get it listed very soon. So this is the world's first cryptographic token which you can get, and for demonstrating health behavior on chain. So you validate the behavior, and then on the other side, you can actually start trading this, and you could even sell it on an exchange, or an insurance company would say, you know what, this proves that you are actually demonstrating health behavior. I'm actually willing to take that token as an insurance premium. So we are actually, as we speak, and I would, I would give you the website of UHT. It's called UHT.xyz, where you can literally go and start earning health behavior on chain. So I think the world of gaming, crypto, AI, and wearables is all going to combine, and it's going to be a very exciting world in the space of healthcare. And I'm so excited that we are all discussing this here.
All right, lots of excitement. I think we've heard, I'll take the privilege of asking the last question and maybe tie some of these together here. But I think we heard a couple things around payment models, or how is all of this paid for, tied into some of your answers. But I'm curious to tease out if there's any others we should think about. So almost infinite possibilities for ways that AI, wearables, gamification could influence health. Is it a tool? Is it a service? And how do we pay for it? We heard it talking about in the MA space. How could giving a device be part of a benefit? I heard it talked about direct marketing to consumers as just their individual motive for better health. And then Vishal, you just talked about it in the last space of a payer creating credits or incentives. We also see, I think, on the provider side, all of the AI tools have a cost to them, and adding this cost to your EMR. And is this part of a practice expense, or is there another way to think about the payment for it? But how else should we be thinking about ways to build in all of the promising technology, either in the AI, the gamification, or the wearable space into payment?
So I would just add that the way we have to think about these tools is not as cost, but investments to save on spending on sick care. So we have data for the NHS. For every pound spent on prevention and digital tools, we've been able to save them £4. So you have to first think about it really about not an expense, but an investment to save. The second thing really is that I personally believe that data is the currency of the future. And that currency is going to get unlocked with tools like the blockchain. And which is why we are very bullish that eventually the data will pay for itself, because this data is going to enable new drugs to be created, new tools to be created. And currently the data is locked in fragmented systems across the world, even though while they're trying to make it interoperable, eventually we believe that it is going to get democratized on a blockchain. And that is what is going to start paying for itself. And finally, all the payers will be able to actually connect these data points directly to claims and even their premiums. And we are already working with many providers where we are able to reduce premiums or increase their coverage based on this data. So that's already happening.
Yeah, I think this is such a good question. I don't know that I have too much more to add. It's a really challenging problem, and there are for any challenging problem there are going to be a number of likely synergistic solutions to this. As I mentioned before, I think showing the data around this is going to be the most important for, and I think as we've had conversations with folks like CMMI around this, how do we incentivize providers to to test these things and to measure the outcomes? Ultimately, I think when we look at what wearable devices can and will be able to do in the future, especially as it relates to detection and screening, it becomes very clear that if a device can, for example, screen for hearing loss, and it's a couple $100, that's much less expensive than a full hearing screening with an audiologist. And if those devices can serve as a makeshift hearing aid, and Apple announced features like that last year, that's way less expensive than a full hearing aid. And so I think you can extrapolate that over other regulated features like AFib detection, like sleep apnea, many others, where the full in-clinic diagnosis can be hundreds or thousands of dollars. And one of these devices could be a few hundred, and hopefully coming down in price over time. So I think there's definitely a path to eventually getting there. We need to measure it. We need to show the data, and then we need to work with organizations that are forward thinking, like Essence and others, to start implementing this in the ecosystem and proving their worth so that these benefits can scale.
I agree with all of that. And I'll just quickly add, as we look at organizations deploying these types of like care at home programs, cost and reimbursement is one of the biggest barriers that I think stops a lot of groups from even getting started. It's why we've seen more traction in some of the areas that have more well-defined kind of value-based payment mechanisms, like the bundled care for total joint replacements, for example. But I agree completely with Ricky on we need to look for the organizations that are forward-thinking, are figuring out how do they do this in a way where they can then demonstrate the value and the savings. Ochsner, with their chemotherapy example that I shared, over that kind of year stretch of time that they had that reduction, they also measured well over $1 million in savings based off of kind of the reduction in what they would have been likely to see for ED visits or readmissions. So I think it's going to be looking at how do we work with organizations like that to identify these are the programs that have real validated outcomes in terms of improved clinical outcome and reduced cost of care, and then figure out how do we standardize that so it's not a negotiation that every provider organization needs to go through on their own to say, hey, here's what we think we can do, here's how we're gonna measure it.
I would like to add as well, if the digital tools and these spaces are able to offer affordable or free versions of these digital tools, especially in the initial stages when more people and provider are not familiar, and consider partnerships to provide access, especially to the underserved communities.
Thank you, Pradnya. So I'd like to thank all of you for joining this afternoon and sharing your insights. You're welcome to stay and listen for as much of the meeting as you can. It is now just a minute after 2:40, and at this time we have a break until 2:50 p.m. Eastern Time. Please join us then, as we have a great lineup for our third session on emerging data strategies for supporting shared decision-making between providers and patients. You're on break.
Produced by the U.S. Department of Health and Human Services.